to our March Huddle. We're fortunate to have Dr. Breay Paty as our guest expert tonight. Dr. Paty will be sharing the concept behind stem cell therapy, as well as the advances in research in this area, including introducing the Vertex VX880 stem cell trial, a trial in which he's the principal investigator in British Columbia. And before I introduce Dr. Paty, I'm going to provide some background about the session, as I always do. We're going to be videotaping this event. That's what you heard in the background. The reason we do that is because there are some folks who can't make it at this time, so they go ahead and watch it on the website or on Spotify. So we kindly ask everyone to mute their microphones unless they're speaking. To make sure that this session runs smoothly, we just have two ground rules. The first one is only one person speak at a time, so be respectful of one another. The second one is if a discussion associated with a specific question goes beyond a reasonable time, I'll just give you kind of a warning, and so the person speaking will have 10 seconds to wrap up their comments. So Dr. Paty is an endocrinologist and clinical professor in the Division of Endocrinology and Metabolism at the University of British Columbia. He completed his medical training and residency at UBC and later obtained an endocrinology fellowship at the University of Washington. He currently practices endocrinology at Vancouver General Hospital, where he attends the solid organ islet and bone marrow transplant clinics. He is actively involved in diabetes and islet transplantation research. He's a well-established investigator in the field and hopes to improve diabetes care, reduce diabetes-related complications, and lay the foundation for the development of new therapies for type 1 diabetes. In addition to his clinical work and research, Dr. Paty is involved in medical education, serving as a mentor and supervisor for medical students, residents, and fellows at UBC. So Dr. Paty is going to present a PowerPoint first, followed by the questions you submitted, and invite questions as well. So if you have any questions, please feel free to just use the chat box. Dr. Paty?
Great. Thanks, Trish. I appreciate that. I hope everybody can hear me okay. Yeah, good. So I'm going to be using slides, and feel free to ask questions or interrupt. This is very informal. Looks like my sharing has been disabled. Maybe we can turn that on. Oh, there we go. Got it. Okay, so my first question is, do you see my screen? Okay, so are we in slide mode now? Are we okay?
It's not in slide mode yet. I mean, I see all your slides on the left, and then the slide you're on.
So slide mode. Let's try again. How about that?
Yes, slide mode.
Slide mode. Okay, good. Great. So my name's Breay Paty. I'm an endocrinologist, and I do deal with diabetes, type 1 diabetes in particular. And I am involved in a variety of different trials, including stem cell trials and islet transplant trials. After my training in Washington, I actually moved to Edmonton, and I was part of the Edmonton islet transplant team for about 6 years before I moved back to Vancouver. So I've been involved in Edmonton and in here. So I'll just go ahead and start. So for those of you who may not be as familiar, islet cells come from the pancreas, and the pancreas, of course, is located sort of right behind the stomach in the abdomen. We call them islets. They're called islets because they look like little islands of cells, and they produce a variety of hormones. And so they're scattered throughout the pancreas, and they produce these hormones that are secreted into the blood. This is an image of islets that have been isolated from the pancreas. This, of course, is highly enlarged. But you can see these are not individual cells. These are actually clusters of cells that all produce different types of hormone. And if we use an illustration of what an islet cluster looks like, this is what it looks like. You can see that there are a variety of different cells. Some of them are called alpha cells that secrete a hormone called glucagon, beta cells, and those are the ones we're particularly interested in that secrete insulin. And then there's so-called delta cells, which secrete a hormone called somatostatin, and then F or polypeptide cells, which secrete pancreatic polypeptide. That's a different hormone. And there are blood vessels running all throughout this little organelle, this little cluster of cells that the cells can secrete hormones into. So this is the thing we're really interested in transplantation. I remind you that we're talking about type 1 diabetes right now, not type 2 diabetes. That's because in type 1 diabetes, you basically have an autoimmune destruction of beta cells. So it's a much more kind of homogeneous problem where people lose their beta cell function. And so replacing beta cells is really a very good and kind of logical approach to treating that kind of diabetes. As most of you know, diabetes is treated with insulin primarily, and you can see that there are a variety of ways to deliver insulin, including insulin injections or pens, or insulin pumps. And this is Omnipod, this is the Tandem, and here's the Medtronic. Many of you may be familiar with these already. But in terms of islet transplant, what happens is that we take islets from a donor pancreas. So somebody has donated their pancreas. We isolate the islets in a special procedure. This is called a Ricordi chamber. It's basically an agitation chamber filled with an enzyme solution. And that enzyme solution breaks down the pancreas and releases these little tiny isolated islet cells, these islet clusters. These islet clusters are then purified and then put into solution. And that solution is then infused back into the portal vein, which is a vein that leads to the liver. Now, we can certainly talk about why the liver, why we choose the liver versus somewhere else. But basically, these cells are infused into the liver and they kind of scatter throughout the liver. And when they're in the liver, they lodge in these little tiny blood vessels called sinusoids. And so these liver sinusoids are very, very small. They're basically one cell width apart. And so the cells lodge in these areas, and eventually we hope that they become engrafted. That is, that they gain a blood supply, they keep living, and they start producing hormone the way they normally would. So the goal is to transplant these little cells into the liver, all throughout, scattered throughout the liver, and hopefully most of them survive and produce insulin. Now, the problem with any transplant is that when you introduce foreign substances or foreign cells into the body tends to react, and it reacts with what we call an allogeneic response, an immune response that attacks these cells, tries to damage the cells, and eventually destroy them. And so in order to overcome that response, we often have to use immunosuppressive medication. What we're hoping for is that we might, let me back up for a second. We might be able to achieve a tolerance of the cells that are implanted. So one of the goals of transplantation is to be able to transplant cells into the body without requiring immunosuppression. That is, that the body becomes tolerant to the cells that are implanted. So it's not attacking those cells, it's accepting the cells as their own. And so you don't need immunosuppression in that situation. Now, immune tolerance is hard to achieve, and we haven't yet achieved it, but that's one of the goals of islet cell transplantation or stem cell transplantation, is that we may be able to achieve immune tolerance. Another way we try to achieve tolerance is that we try to encapsulate the cells. So there is an approach by which we take this cluster of cells and we surround it with a membrane. And that membrane can be made of a variety of substances. It can be either foreign substances, or it can be sort of encased in a kind of an alginate layer that hopefully will keep out many of the antibodies and the cells that tend to attack and break down the islet cells, but it will still allow in some of the vital nutrients like oxygen and glucose and other nutrients to keep the cells alive. So encapsulation is one of the mechanisms or one of the approaches we use to try to achieve, if not immune tolerance, at least a minimal use of immunosuppression in these transplanted patients. And of course, you want the cells to be able to produce insulin and secrete insulin freely into the bloodstream. There's a variety of different approaches to encapsulation. One of them is called microencapsulation, where you basically take an islet cell and you surround it by an immune isolating capsule. And there's a variety of different ways of doing this. But this is obviously a tiny little capsule, basically just coating one islet. And then you infuse those cells either into the liver, or perhaps you put them underneath the skin, or maybe you can put them in the omentum to hopefully survive and secrete insulin. There's another way of doing it, which is called macroencapsulation, where you actually take a foreign substance, like in this case, you have a little sort of packet that you infuse the cells into. So you put the cells, this is obviously manufactured. It's about, you can see that there's a quarter right here. It's about the size of 3 quarters. And you infuse the cells into this, and then you implant this usually under the skin, but sometimes in the omentum, in the GI tract. And hopefully this will protect the islets and keep the immune system from attacking them. And you can see that blood vessels can sometimes grow through these encapsulate devices. And the problem with blood vessels growing into the islet interior here is that they can also allow the immune rejection to occur. So macroencapsulation is still being investigated, but it's something that we're certainly hopeful for. In terms of transplant sites, as I mentioned, the liver is the primary transplant site for this particular trial, but there are other transplant sites as well. You can have microencapsulated devices and transplant it into the peritoneum or into the omentum, which is the kind of the fat surrounding the GI tract. Or you can take these devices and implant them under the skin. And in fact, UBC is involved in a trial right now where we're implanting these macroencapsulation devices under the skin. What about reasons for having an islet transplant? Why would somebody want an islet transplant, especially given the variety of different ways we have of delivering insulin? Well, those of you with diabetes know that despite the fact that we have a variety of different ways like insulin pumps and continuous monitors, people still struggle with their glycemic control. You still have a lot of highs and lows. It's still very challenging, very difficult to titrate the insulin properly. And so a lot of people still have frequent episodes of hypoglycemia despite their best efforts, despite being on basal bolus therapy, maybe an insulin pump or a continuous monitor. They may develop what we call hypoglycemia unawareness, that is not being aware of their low blood sugars, not feeling their low blood sugars until maybe it's too late and they have a severe low. Or they have progressive complications. They might have retinal damage or eye damage. They might have nerve damage or kidney damage that is caused by hyperglycemia. And so if we can improve the blood sugar and reduce the incidence of hypoglycemia by an islet transplant or a stem cell transplant, that may be very helpful for some people, although not for everyone. Now, as you know, there are a variety of different problems with islet cell transplant, and that is islet cells that are from donors. And that is that the cells have to be isolated from the human pancreases. It's not just a matter of removing the pancreas and just putting it into someone else. You have to isolate the islets. And that takes a lot of time and effort, and it requires a lot of experience. It's very expensive. So it's not easily done. And also the whole process of isolating the islets actually causes damage to the islets themselves. So it's a very fine line you're walking when you're trying to isolate islets, but not cause too much damage so that they still survive and can be transplanted and produce insulin. So these are all potential downsides to islet cell transplant. Also, we lack donors. You know, we don't have that many donors. Even in a province like BC or Ontario, there are just not enough donors for all of the people who may want or benefit from transplant. On average, we would do maybe in a good year, we might do 12 to 15 transplants a year. On a bad year, we're only doing 1 or 2 transplants a year. So you understand that the number of donors, the shortage of donors is a big problem. And then, of course, we talked about triggering the immune system, and the donors have to be matched to the recipients and the need for long-term immunosuppression with standard islet cell transplant. Also, there tends to be a decline in function. I'm not going to show this data, but we know that islet cells tend to decline with time. So even if somebody achieves insulin independence, within a couple of years, often they're back on insulin and their islet cell function can decline. So it's certainly not a cure for diabetes. It's more of a treatment. And this is something that obviously we're trying to improve. So what about stem cells? How will stem cells improve this? Well, first of all, a stem cell, as you know, is a cell that can replicate itself and can differentiate into many different types of cells. So in the case of diabetes, when you compare it to human islet sources, you require at least 2 pancreases to get enough islets to become insulin independent for one person. You have to purify the islets, and in the end, you only get about 10 to 20% of the donor islets that survive and actually are able to function within the individual. Whereas if you get cells from a stem cell source, the cells potentially are unlimited. You can expand the number of cells by simply causing them to differentiate. And then they mature into insulin secreting cells. You can then freeze them and transport them. And you have essentially unlimited doses of cells that you can use for a variety of recipients. What we don't know is how these cells function when they get into people. We certainly have done preclinical studies where people transplant cells into mice and rats, sometimes into small mammals like pigs or even monkeys. And it does achieve insulin independence, but it's very different when you're transplanting into a person. So what we're doing now is we're starting these stem cell trials into individuals to see how these cells respond in people. The strategy for this particular trial is that you're taking a stem cell and you're kind of coaxing it into developing into a mature beta cell. You see the variety of steps in this, and I'm not going to go through each of the steps, but it's sort of like a cookbook. You're adding different ingredients at different stages to cause the cells to mature and differentiate so that eventually you end up with these beta cells. You transplant them very much the same way as you would transplant islets. You put them into a solution and then you infuse them into the liver. In this case, we're using the liver as the primary site of transplant, but that may change with time. There may be situations in which we use the omentum, or maybe we'll use under the skin. There's certain other trials that are doing that. So it's not that the liver is absolutely required, but so far the liver seems to be the most hospitable and the most successful place to transplant islets and possibly stem cells. Obviously, there are risks involved with any kind of transplant procedure, whether it's stem cells or islets. There's what we call procedural risks, which would be anytime you're infusing something into the portal vein or the liver, you could have bleeding or hemorrhage. You could have blood clot formation or portal vein thrombosis, or you could actually puncture the gallbladder because it's right in the same area. So that's happened on occasion with islet transplants. The other major downside or risk is immunosuppression, and you can see that there are a variety of different risks associated with that. That includes things like nausea, diarrhea, possible kidney damage. There's an increased risk of infection, and there's certainly an increased risk of certain types of cancers, mostly skin cancer and blood cancers. So these are all real risks of islet transplant and immunosuppression. So it's something that we have to tell people if they're considering a transplant, whether or not those risks are worth it for them. Right now, the stem cells are in just the phase 1, maybe phase 1 and phase 2 of clinical trials. So those of you who are familiar with the different phases of clinical trials know that before trials get to humans, they're extensively studied in animals. So we study them in mice and rats and small mammals, and we see if they're successful there. And if they're successful there, then we get approval to use them in people. And these have to be approved not only by the government agencies like Health Canada or the FDA in the United States, but also by individual institutions. So they have to be approved by, for instance, UBC or VGH, Vancouver General Hospital, to be used in this setting. Right now, what we're talking about are phase 1 and phase 2 trials, which is basically establishing the safety of these stem cells and the efficacy. How do they really work? Are they going to really produce insulin when you infuse them into a person? Once you get to phase 3, you've already established most of the safety and efficacy. So really, phase 3 trials are more about dosing, more about, okay, we know that they're safe, we know that they work. How many of them do we need, and what's the best way to use them? And then phase 4 is just after they've been approved. So if something is already approved and it's already on the market, then you would do phase 4 trials, which are follow-up trials. We're nowhere near that right now. Where we are is phase 1 and phase 2. The current trial that I'm involved in is the VX-880 trial. It's a stem cell study. The stem cells came from Boston. They were developed in a lab in Boston at Harvard University. And they were developed by a very, very senior investigator. And they have been approved for use in humans in the United States and in Canada. And these are the criteria that if someone wanted to be involved in the study, that they would have to meet. They'd have to be over the age of 18. They'd have to have type 1 diabetes for more than 5 years. They have to be using basal bolus or insulin pump. And they have to use a continuous monitor for at least 3 months prior to the transplant and have at least 2 episodes of severe low blood sugar or hypoglycemia in the 12 months prior to their enrollment. The other thing we're looking for is people with blood type A. Now you might say, well, why blood type A? And we don't really know the answer to that, but we know that in many, many trials with stem cells and islets, people with blood type A seem to be more successful, have better outcomes than people with other blood types. I don't know why. I don't think anybody really knows why, but in this particular trial, they are asking for blood type A. I'm just going to put the name of the study coordinator and their contact information. Her name is Nicola James. If anybody's interested in learning more, you can just contact Nicola, either at her email or her phone number. And of course, she'd be happy to tell you about it. Even if you don't think you meet the criteria, you can still contact her if you're interested. And we do have a handout for anyone who contacts us. That's all the slides I have. I don't want to go too long, but I'm happy to answer questions. So I'm going to stop sharing now.
So Dr. Paty, you have one question in the chat box. I'll start with that, now two questions. How much has it been done to market, to educate donors about the stem cells?
Yeah, that's something that we're in the process of. You know, stem cells have been around for a while. People have been talking about stem cells, but very much in an abstract sense. This is the first time really in the last couple of years that we've been using stem cells in a real clinical setting, that is in a clinical trial. There's another trial that's going on that's been going on for the past 2 years called the ViaCyte trial. Some of you may be aware of that. The ViaCyte trial uses encapsulation devices implanted under the skin. This particular trial is not like that. This is an infusion of stem cells into the liver. So it's a different approach than the ViaCyte trial. But I think the more we talk about it, the more I have a chance to talk to people like you and others. You know, people get, or at least aware of these trials. And I think we're going to see more and more of these trials come on in the next 5 to 10 years. So by no means are we talking about, you know, we've reached any kind of milestone here. We're really talking about another step in our understanding of the development of stem cells for the use of diabetes.
Arm, if you're here, do you want to follow up? Oh, you are here, of course, because you submitted the question. Did you want to follow up?
Yeah, sure. If someone can call me, I would like to talk about it some more. I'll send you my contact number.
Sure,
Okay.
you can send it to me, or you can send it to Nicola, the address I left, and I can.
Yeah, because
Yeah,
because I feel like you know, we're lacking you know, educating donors, and I think it's something very simple, but it has to be done. Whenever we have to give something out of our body, it's very difficult to sell. And I think we need to do a little bit more work. All the agencies have to get together, and we need to do a little bit more. I've been diabetic since I was 19 years old. I'm like 39 to 40 years now, and I feel like we're already late because more stuff is coming out now. Not to say that work wasn't done before, but I feel like we're getting closer now than ever we have. I mean, still, I mean, we have to be hopeful. I'm not saying that this is an easy thing for you guys to, because a lot is involved. Because when you just explained to me about, you know, the phases, I'm like, oh my God, a lot of work has been put into this, right? So it's nothing like a person sitting here, even being type 1, can even understand what you just said. So thank you very much for all that work that you guys are doing.
I'll jump in here if I could. You know, just at our institution alone, we've been working on this particular trial before we're even going to enroll anyone. We've been working on it for 2 years, and that's just to get it through all the approval process, get all the infrastructure in place, get everyone on board, understanding what we're doing. And this is within a medical institution. This is people who deal with this kind of thing all the time. So you can imagine that, you know, doing this in a large scale takes a lot of work, and it takes a lot of time, unfortunately. And there are a lot of safeguards that are in place. And so we understand those, and we're willing and happy to work within those safeguards, but it does take a lot of time. It does take a lot of time. Tricia, if you don't mind, I can just try to answer some of the questions in the chat. Is that okay?
Sure. Okay.
So the first question, the next question, I guess, can you live outside the Vancouver area? Absolutely, yes. Right now, for this particular trial, we're recruiting mostly in Western Canada, but mostly in BC. There is a center in Edmonton, so I'm sure they're recruiting from Alberta. Yes, the answer is yes. In fact, we would accept anybody from anywhere in Canada. I'm sure that people in Ontario wouldn't want to come all the way out to Vancouver. They have a center in Toronto as well. But we would accept pretty much anyone in Canada. So yes, the answer is yes. What is the definition of a severe low blood sugar, and is type A included, is A plus included in A blood type? I'm assuming that you mean A positive blood. Yeah, that would be type A, that's correct. Definition of severe low blood sugar, that has a very, very qualitative definition, if I could say that. It doesn't mean an absolute number. What we mean when we say severe low blood sugar is that someone can't help themselves. They require assistance from someone else in order to treat their low blood sugar. And it's not just a matter of saying, oh, I'm feeling low, could you get me a glass of juice or get me a Coke or something? It would be that they reach a point where they literally can't help themselves. And that's a severe low blood sugar. It doesn't matter what the number is. It's in that situation, we call it a severe low blood sugar. The next question is, does this study require immunosuppression drugs? The answer is yes. That's one of the downsides of all of these early trials, is that we still require immunosuppression because we haven't really reached the point where we can identify and develop stem cells that are not immunogenic. In other words, that don't stimulate the immune system. So even the stem cells, because they're derived from people, they're derived from embryonic stem cells, they do still stimulate the immune system. So we do require immunosuppression, but our hope is that eventually we'll be able to develop cells that do not require immunosuppression. That's the whole idea. One of the next question is, are donors usually, have they usually passed away? So I want to be clear, when we talk about donors, we're talking about traditional islet cell transplant. That is, we've been doing that for about 20 years. We've been transplanting people, taking pancreas from donors who have passed away. Absolutely, you cannot donate a pancreas. You only have one pancreas. You can't donate it yourself. You have to be passed away. But if we get a donor that's passed away, we have a suitable pancreas, we process that, we isolate the islets, then we can infuse them. That's traditional islet transplant. The study we're talking about right now is not traditional islet transplant. It's stem cell transplant. Those stem cells do not come from donors. They come from a lab where the stem cells have been developed over many, many years. So it's a very different process. But yes, traditionally, donors have passed away. I see someone's from Toronto. Absolutely, we would accept anyone across Canada, but of course you do have a center in Toronto, so you may want to contact them. I don't know their contact information, but I'm sure you can contact the University of Toronto and they can put you in touch with them. If you're A negative, is that fine? Absolutely. Any type of any blood type would be satisfactory. The next question, why are islet and stem cells placed in the liver rather than directly into the pancreas? That's an excellent question. So mostly, you understand that islets originate in the pancreas. That's where they are. Why they're there, no idea. Because honestly, the pancreas is not a hospitable place for islets. The pancreas has two functions. One is to produce insulin and other hormones. The other is to help you digest food. And in order to help you digest food, what it does is it produces a lot of enzymes. And those enzymes actually break down cells. That's how you end up digesting your food. It secretes those enzymes into your stomach or into your GI tract, helps break down the food. The problem is that if you start manipulating the pancreas, if you start touching it, if you remove it, all of those enzymes that are contained within the pancreas, they start to leak out and they start to damage the cells around them. So when we try to isolate islets from pancreases from donors, we have to be very careful that we're not just causing more damage just from handling the pancreas, just from manipulating it. So the reason we don't infuse it into the pancreas is because the pancreas is actually not a very hospitable place for islets if you're trying to infuse them. The liver is much, much more hospitable than the pancreas. I hope that makes sense. Next question.
Thank you.
Sure. Next question is, most of us are on insulin pump and CGM. There's less chance of severe lows. And so that's absolutely true. one of the things that we've learned is that the improvement in technology over the past 10 or 15 years has made it even more important that we try to be absolutely safe when we're doing any kind of trials like this. And the bar has been raised, frankly. So there is a pretty strict criteria for entry into this trial. You do have to have at least 2 severe low blood sugars in the past 12 months. That's a pretty high bar. Not everybody meets that bar, especially if they're using CGM. So, but that's the way things are because technology has improved, and that's a good thing. So I'm putting out the word to anyone who, if they feel that they might qualify, of course, you can contact the study coordinator and you can ask more questions. You can ask about it. And if you don't qualify, well, then that's unfortunate. But what we're trying to do is we're trying to find the right balance between the risks of the study, and there are real risks, versus the potential benefits. And we feel that having somebody with severe low blood sugars is the right balance to achieve. There's another question, already on immunosuppression for arthritis, would they need a different drug, or would one immunosuppressant cover both? Unfortunately, for this particular trial, if you're already on immunosuppression, you would not be eligible for the trial. I didn't put up all of the criteria, but basically they only would accept people who are not currently on immunosuppression. The reason for that is because you would require additional immunosuppression if you entered the trial, and any immunosuppression you were already on would have to be stopped. And of course, that wouldn't be good for whatever condition like arthritis or whatever condition you had. So unfortunately, if you're already on immunosuppression or already had a transplant, I'm afraid that you would not be eligible for the trial. Next question is, would you go over the what type 1 diabetes goes through if a person in your study? In other words, what happens? So the way it works with these trials is that this is a series of steps. It's a process, basically. If you contact the coordinator, they will get back to you. They'll basically just send you an information sheet, and the information sheet will have just basic information. And then you read it over and you decide, okay, maybe I'm interested, maybe I'm not. If you're not interested, then that's it. You don't do anything else. If you're interested, you contact them back and you say, I've read this and I feel like I might be interested. And she says, okay, well, why don't you come in and we'll talk a little bit more about it. And they talk about it, and then they do some very basic tests, like some blood tests, maybe do a blood type, see if you're type A or not, and do some basic history and physical examination. From there, they decide whether you might be eligible. And then if you might be eligible, then they do more intensive investigation. And in this particular trial, they would send your information anonymously to an oversight committee. This trial has an oversight committee that's based in Boston that would it would be anonymized. So they wouldn't know who you were. They would just have your information, but they wouldn't know your name or anything. And they would say, okay, this person meets the criteria or they don't meet the criteria. If you meet the criteria, then you potentially could be enrolled in the study, but then you have to go through a consent process. You have to actually agree to the study, and we have to sit you down, and so you have to go over everything again and say, look, this has real risks. Are you sure you want to do this? And then if you say yes, you have to sign a form. And then once you sign the form, then you would be enrolled in the study. Once you're enrolled, then we would have to arrange for the transplant. So we would have to transport the islets to Vancouver. We have to arrange for people to come into hospital. You would spend about a week in hospital. The first 3 days, you would be on immunosuppression. Then you would get the procedure. And then for another 4 or 5 days, you'd remain in hospital just to make sure that nothing went wrong. So it'd be a total of about a week. And then after you're discharged from the hospital, assuming nothing goes wrong, then you would probably still be on a little bit of insulin. And then we would monitor over time, usually once a week in the beginning, and then eventually once a month, and then eventually every 3 months. The total duration of the study is 5 years. So you would be committed to 5 years of follow-up. But of course, anybody who enters this trial can always withdraw from the trial at any time. That's their right. So even if you decided that you didn't want to stay in the trial, you have the right to withdraw. So I hope that answers the question. I know it was kind of long-winded, but I hope that answers the question. How long do you estimate it will be before all eligible type 1s can receive stem cells? Again, very difficult question to answer. I've been in this for a long time. I've been doing this for about 25 years. And when I was a resident, they talked about cures for diabetes, and I'm sure all of you have heard that before. So I'm not going to sort of tell you about that. All I'm going to say is that this is another step in the process of learning about how we can replace beta cells. And we're trying to do it in a way that doesn't rely on donors, because anything that relies on donors, we're going to have a shortage. We're not going to be able to meet the demand. At the same time, people are working on lots of technologies that are improving glycemic control for people with diabetes. So, I hate to say this is a competition, because it's not a competition, but in essence, on the one hand, we're talking about cell therapy, and on the other hand, we're talking about technologies, and they're both improving. They're both really improving. I think the last 10 years, really technology has taken the forefront in terms of managing diabetes. But who knows? All it would take would be one breakthrough, and then cellular therapy may go beyond technology. So this is really what we're hoping, is that we can make progress in this area. Time frame is difficult to tell. Why do you need to have 2 severe lows? That's a really good question. This trial is very strict. It's probably the strictest trial that I've been involved in. And I think the answer is, anytime you're dealing with a new technology, especially cellular technology like stem cells, you want to be absolutely sure that the person you're transplanting has a real need for that transplant. You don't want to sort of have someone who is generally well controlled, they're using their pump, they're on the continuous monitor, and they're kind of doing okay. Their A1C is not bad, they don't have a lot of complications. That's not the type of person that you want to take a lot of risks with. And so it's not the type of person we would want to put on immunosuppression or put them through some kind of risky procedure. We're interested in transplanting people who are really having challenges, who are really having lots of lows, who are having difficulty managing their diabetes. And so we feel that the balance between the risks and the benefits weigh toward the benefit instead of toward the risk, if that makes sense. What about those on, somebody's going to have to help me here, DMTs? I'm not sure what that means, DMTs. Does anybody know? Okay, I'm not sure what that means, so I hope I can answer it eventually. I'll move on to the next question. Is the idea that once the stem cells are inserted, that the participant would stop taking insulin, or is there an estimation for how long they will last? Those are all great questions. I'm afraid I don't have the answer to that. Of course, we would like it if they produced enough insulin and enough insulin to come off, enough insulin from the cells that they could come off insulin. In fact, there was a report last year in the New York Times involved with this particular trial where one patient did come off insulin. But I can't promise you that that's going to happen in everyone. So, the whole purpose of doing these trials is to learn about whether these cells are actually working, whether people can come off insulin, whether they can reduce their insulin, whether they reduce the chances of low blood sugar, and how long they last. Are they going to last for a long time, or is it just a short period of time? So these questions are all very important, but that's exactly why we do these kinds of trials. Next question is, has it been found to reduce liver function? The answer is no. These cells are very, very tiny. Remember, we're talking about microscopic cells here. You wouldn't really be able to see them with your own eyes. So if you were looking at the solution they were in, it might look a bit cloudy, but it doesn't really look like much of anything. So once you put them in the liver is quite large. And so when you put these cells into the liver basically doesn't really react that much. Sometimes you get a little bit of elevation in liver enzymes, indicating there might be some inflammation in the liver, but that's usually temporary and it settles down within a day or two. And so no, the answer is no. At least so far, we don't think so. With trials on traditional islet transplant, we did see that around the islets, the cells seem to develop some fatty tissue. In other words, fat accumulation around the islet cells. And we think that's simply a response to the local insulin secretion, because insulin tends to cause fat storage. So these cells were secreting insulin, and the little fat cells were kind of gathering around these islets. And so we called that hepatic steatosis or fatty liver, but it was very minor. It was a minor thing. And we haven't really seen that in this particular trial, but of course, it's too soon to tell. We'll have to wait and see. Let's see. Zero alcohol consumption. That's a good point. You know, I don't know the answer to that. I suspect that in the beginning, yes, you would not be able to drink alcohol, but eventually I suspect that you would. To be honest, I'd have to double check that, but yeah, that may be one of the initial requirements. Is there an age criteria? No, there's no age cutoff, but you have to be over 18. So you can't be under 18, and you have to have diabetes for at least 5 years. What else? I attempted an islet transplant in 2004 to 2006, study with Dr. Thompson, underwent 2 procedures, 6 months apart, but the second one did not result in any improvement. I ended up reducing my insulin intake for the first transplant, but at the same time, there was a sub-study where I was taking not just immunosuppression, but some other drug. That was probably a GLP-1 agent, like Ozempic or something like it. Didn't recall what exactly it was. In the end, didn't feel well enough to continue and had to stop the study. Yeah, that does happen. I'm not sure if I know this person, but occasionally people, the immunosuppressive medication does have side effects, and some people feel a lot of side effects. They feel fatigue, sometimes nausea, sometimes generalized weakness. So the answer is yes, some people don't tolerate the immunosuppression well, which is another reason why we have to find the right balance, right?
Dr. Paty, it was me who did that. I'm the one who wrote that. Hi. My question was with the stem cell, will there be a sub-study as well, or is it just strictly immunosuppressant?
In the beginning, it will probably just be the immunosuppression. It probably won't be a sub-study. The reason for that is because this is a protocol-driven trial. The islet transplant studies were clinical trials in that we had the option of changing the circumstance. We could change the medicines we used, et cetera. This trial is absolutely protocol-driven. It's all have to be approved by an ethics committee. It's done absolutely with strict guidelines. We don't have much room to change the protocol. So the answer is no. We would be strictly adhering to the protocol. Okay, we've got a couple of more messages. I'm not sure what you mean by disease-modifying therapy. Oh, I see, DMT. That's what you mean. Oh, I see. Okay, so let's go back to that question with DMT. What about those on DMTs, disease-modifying therapies? I suppose it depends on which one there is. I would have to double check. You know, that's why we bring people in to see if they're eligible, because everybody has different circumstances. Everybody has they're on different medications. If you're really interested, you would contact the study coordinator and they would go through all of the different criteria with you. And then they can work out with you whether or not you would be eligible.
It was me that wrote that, Corinne here. Disease modifying therapy is for MS. I'm a lucky winner of 2 autoimmune diseases, so
yeah,
that's why I was asking.
My guess is that it probably would make you ineligible, but to be honest, if you're still interested, contact Nicola and she can give you more information.
Great, thank you.
Okay. I don't see any other questions, Tricia. Do you have any other questions for me?
Yes, we have questions that were pre-submitted, so I'm going to go ahead and ask you. One from Anonymous. Is it helpful to use stem cells held in a laboratory and extracted at birth for a type 1 teenager? My 17-year-old daughter was diagnosed at 16 years of age with type 1, and I'm interested to know if it would be helpful to use her stem cells held in laboratory as part of the research.
That's a really, really interesting question. You know, that would not be possible in this particular trial because the stem cells involved in this trial have been developed already in a lab. They're already in the lab. They don't have another source for them. Ultimately, though, what we're hoping is that, especially if we want to develop immune tolerance, if we can have stem cells from an individual, that is taken from someone, either at birth or even as an adult, if we can take some cells and then sort of de-differentiate them, get them down to the stem cell level, and then develop them into another cell line, that is like an islet cell or a brain cell or a heart cell, that would be ideal because theoretically then that would not be immunogenic. That wouldn't cause an immune reaction because essentially they're the cells from the person. So it would be tolerated or accepted as their own cells. So in an ideal world, That would be perfect. That would be actually what we would prefer rather than have a separate stem cell line. But we're not there yet. We just don't know how to do that. So right now, we only have cells that are derived from these embryonic stem cell lines. But in the future, will that be possible? I hope so. Is it possible now? No.
All right, so that actually answers the next question, which I just want to read still. I'm storing my daughter's stem cell cord blood that we collected at birth. If there was a cure using this new therapy, would those stem cells help me or just her? So,
Well, again, I'm going to go back to anything's possible with the right understanding, the right knowledge. We're right at the beginning of using these cells clinically. Obviously, ongoing research is needed to be able to develop cells that are individualized for each patient, whether they're from stem cells from cord blood or whether they're just, there's the ultimate idea would be that you could just take what we call a buccal swab. You just do a swab of the inside of the cheek, get some cells, take them to a lab, de-differentiate them. So you break them down into stem cells and then you remature them into different cell lines. And then you re-implant them into a person and they would be accepted as that person's cells. That would be the ideal. We just don't have that technology right now. So is it possible we'll have it in the future? Absolutely. We'd like to hope we could. We're just not there yet.
I think you have another question in the chat box that just popped in.
How hopeful are you? I know now that I'm 60, my chances for any intervention are less. So remember, there's no actual age cutoff for this trial. You have to be over 18, but after that, there's no age cutoff. Like I said, the response to islet transplants and even stem cell transplants seems to be variable. Some people respond really well, other people maybe not so well. That's why we're doing these trials. We're trying to understand why some people respond better than others and what the factors are involved in that response. So it's not about studying the cells, it's as much about studying the people and their response to these treatments as it is about studying the cells themselves. They've been studying these cells for 20 years. Now is the time to study what happens when you actually put them into people. And so that's why we need people for this trial. So, I wouldn't necessarily say that anyone is too old for the trial. But I would say that, we want to make sure that whenever we use a new technology like this, that we feel that the risks are worth the benefit. So that's the major thing we want to get across.
Okay.
What about using stem cells from your twin? Again, you're talking about a monozygotic twin, I guess, like an identical twin. The answer is yes. Theoretically, those cells could be accepted into your own body because it's the same genetics. There have been twin studies actually with half pancreas transplants. So they've taken the people with diabetes. They've taken half of the pancreas from one of the twins who did not have diabetes, and they transplanted into the second twin who did have diabetes. And the unfortunate part is that the second twin, although their blood sugars improved, they were never able to come off insulin. So is it possible that you could develop stem cells from a twin? Yeah, absolutely. But again, it would be the same thing as developing stem cells from your own body. That if you took a cell from your own body and then de-differentiated it and then developed it into a cell, then that would be kind of the same thing.
Okay, next question. Any ideas on stem cell use to stop diabetic retinopathy?
Yeah, so diabetic retinopathy, as you know, has been closely linked to blood sugar control. In fact, among all the different complications, diabetic retinopathy is the most closely linked to your A1C, that is your absolute blood sugar control. So to the extent that stem cell transplants or islet transplants improve blood sugar control and lower A1C, they will improve retinopathy. And in fact, studies have shown that. There was a study, actually somebody mentioned Dr. Thompson. Dr. Thompson did a study probably 10 or 15 years ago now that demonstrated that there was stability and improvement in retinopathy in people who received islet transplants. It was one of the few studies actually that looked at this problem. So the answer is yes. Now, can we say that with stem cells? Not yet, simply because we just don't have enough patients. There haven't been enough people transplanted in the world to know whether or not it will improve retinopathy, but one could assume that if it improved blood sugar, it would also improve retinopathy.
Okay, next question. What expectations of stem cell therapies without immunosuppressive drugs do we have?
What options without
Do we have any expectations that we'll ever be doing stem cell therapies where you don't need immunosuppressive drugs?
Oh yeah, absolutely. That's the goal. That is the absolute goal. Nobody likes immunosuppressive drugs. I don't like them. Nobody likes them. We just have to use them if we're going to transplant people. But is the goal to get away without immunosuppressive drugs? Yes. Islet encapsulation. I told you about encapsulating islets to put them into the body. One of the goals of encapsulation is to try to get away without immunosuppression. So far, we haven't been able to manage that. But again, we're always trying. So the hope is that we will eventually get there. We just don't know when.
All right. What is the % success rate of stem cell therapy among type 1 patients?
That's a good question. That's a question that I cannot answer. And the reason I can't answer it is because that's exactly what this trial is supposed to do. We're doing these trials to find out how successful they are. What percentage of patients can come off insulin? How do you have a decline in islet function over time or stem cell function over time? We don't know the answer to those, and that's why we're doing these studies.
Okay, next one is it available for those who've had diabetes for more than 40 years? Does it matter how long you've had diabetes?
Absolutely, it doesn't matter. You have to have diabetes for more than 5 years, and you have to be over 18, and there's a variety of other inclusion criteria. But no, there's no age or duration of diabetes requirement other than those.
Okay, just 4 more. Anonymous, is this similar to the ViaCyte research?
Right. So the ViaCyte research actually started a little bit earlier. So it was about 2 years ago that they started the ViaCyte trial. Many of you may have heard of that. That's the encapsulation study where they're actually putting it into those devices that I showed you, and they're actually implanting it under the skin. And right now they're doing a trial of 6 of those devices, actually taking 6 of them and implanting them subcutaneously. So they do an incision in the skin and they put it under the skin. This cell line is a different cell line from the ViaCyte cell line. It's a different cell. It was developed, ViaCyte is from California, I think, and this Vertex, or the stem cell that we're using, is from Harvard, from Boston, but very similar in sort of concept, that you're taking a stem cell, you're implanting it into someone, and you're hoping that it produces insulin. There are a variety of differences between them, but in essence, they're very similar. But in this case, the technique is different because we're implanting it into the liver rather than in the subcutaneous tissue. I see that there's some other chat questions, if I could.
Yes.
One of them is this study using the CRISPR encapsulation? So those of you who may not know, CRISPR is a molecular technique by which people can modify DNA. And if you modify DNA, then hopefully you can develop different cellular functions. You may be able to delete abnormal DNA. You may be able to cure certain conditions with this technology called CRISPR. I'm not a basic scientist, so I don't pretend to be an expert in this area. But in essence, yes, the answer is yes. Basic scientists are trying to use the CRISPR technology to improve the antigenicity of stem cells. So if they can get rid of a lot of the antigen sort of proteins on the cell surface, then they might be able to develop a cell that isn't antigenic, that doesn't stimulate the immune system, and maybe that doesn't require immunosuppression. Now, am I an expert in this? Absolutely not. But yes, that technology is being used. It's not being used in this particular trial, I should say, but it is being used. Okay.
I have another question. What is the sample size for the study you're doing?
This is a phase 1, phase 2 trial, so it's a small trial. Total worldwide, we're probably looking at maybe 17 or 18 patients. So we're not talking about a big trial here. In Vancouver, we're hoping to get 1 or 2 people at most. So we're talking about a pretty small trial, but that's the nature of these kinds of studies. When you have a phase 1 trial, you don't have hundreds of patients or thousands of patients. You're talking about just a handful of patients.
Okay, and last question. You probably answered it, but it's worth repeating. What are the risks to participants or any uncertainties of risk in this study?
Yeah, so I can't go over all the risks for you today. I think I mentioned some of them. Remember, this is an immunosuppression trial. You will be required to go on immunosuppression, and there are risks to that, including risks of infection and risks of potential malignancy, that is cancers. Although those are low risks, they're real. There are risks of the procedure because you have to get the cells implanted into the liver, and that requires a catheter to be placed through the skin and into the portal vein. That portal vein leads to the liver. People can have bleeding and blood clots from that. Now, these risks are not high risks. In fact, we do this kind of procedure fairly frequently, and we have very, very few complications. But of course, we can't say that there are no risks. There obviously are risks. So, but that's the nature of these kinds of trials. You have to weigh the risks against the potential benefits. So we would go over all of the risks in great detail, probably more than the person would want, when we're consenting them for any trial like this. So I can't explain all of them right now, but I've explained some of them to you. Sorry, I think you're muted, Trish.
Yeah, you're right. Let's thank Dr. Paty for joining us in our March huddle and sharing information about the VX-880 stem cell trial, as well as just teaching us about stem cell therapy. I want to thank, and so I'm just going to clap. I'm sure everyone is going to clap, but you can't hear it. Thank you, everyone who attended tonight. We really hope you enjoyed this session. And again, if you have any topics that you want to have highlighted in the huddles for the future, please just let us know, and we will find the expert who is in that area. And again, Breay, thank you so much. I learned actually a lot from you today, and I think you're a great educator. I can see why people like you for education. Okay, so any other questions, last minute things before we sign off for the night? Okay, great. Thank you again, Dr. Paty.
Thanks so much, guys. Take care.